Excellent. Thank you all for coming back. I hope you had a nice little lunch. I know there wasn't too much time today, but welcome back. My name is Justin. I'm the community health educator for the Central and Eastern Washington for the Washington Poison Center. It's nice to host you all here today. Quick housekeeping reminder, this season runs with new speakers and topics every Tuesday this month. We still have tickets available, so please don't hesitate to invite your colleagues, friends, family members, neighbors, anyone you think will appreciate the content of this series. Fun fact, my neighbor has actually been showing up for the series, so that's pretty cool to see. Thank you to our sponsors. We work for Health Washington, Washington State Department of Health, Drug User Health Program, and Teen Health Hub, as well as the Washington State Healthcare Authority and the Friends for Life program. This is our first year with sponsors, so we really appreciate the early adopters. Additionally, as participants who are tuning in, you are muted, so please direct questions and comments to our chat box. It's on the Whova platform there. And finally, if you want a certificate of attendance, you'll need to take a survey that will be emailed to you from Whova at the end of the series. Now for our great guest today. Dr. Zhang is a pharmacist and the Director of Professional Affairs with the Washington State Pharmacy Association. His background includes academia and pharmacy advocacy. His work with WSPA includes research projects regarding MOUD, medicines for opioid use disorder, medical billing, and pharmacy career advancement. Joining also is Dr. Bacci, sorry. Dr. Bacci's work focuses on expanding the role of community pharmacies in patient care, particularly through sustainable models that support services like medications for opioid use disorder. She applies implementation science to help translate promising ideas into everyday practice. Dr. Bacci is also a network facilitator for CPESN Washington and a leader of the Academia Community Transformation Pharmacy Collaborative, both of which bring together pharmacy teams committed to advancing care in their communities. So with that, I welcome you both. Thank you so much for joining us. Thank you for the participants, attendees that are showing up as well. And let's get this started. Thank you.
Awesome. Thank you very much, Justin, and hello, everybody. We'll just get things started then. So today we'll be presenting on some research that we've been doing specifically around community pharmacy and MOUD access. We'll save questions until the end, but feel free to either throw them into the chat or keep them until we finish our presentation. So to kick things off, the learning objectives for this presentation, we're first going to define community pharmacy and MOUD and also connect those two. We're then going to identify how community pharmacy can have an impact in the MOUD space. So basically what our research has shown, and then recognize two different models of care that can be implemented in a community pharmacy to provide care for OUD patients. Just showcasing some of our research results as well as then next steps that we hope to take based on what we learned from our project. So the first thing I'm going to do is a quick history lesson. I'm not the best at social studies, so I'm going to try to make this quick. But in terms of legal and regulatory barriers, when it comes to addressing MOUD, of course, we just start with the data or Drug Addiction Treatment Act of 2000, right? That sets standards for what healthcare providers can do when it comes to addressing opioid use disorder, specifically looking at setting regulations for what additional training is necessary for healthcare providers to provide that level of care. But one thing the part of these acts didn't include was pharmacy, right? Pharmacists are highly trained healthcare providers. We have doctorate degrees. However, just given prescribing barriers and limitations, we weren't seen as someone who could potentially either be someone who helps in the prescribing of medications for OUD or even being like an access point. As things continue to progress, especially in Washington, then in 2017, the hub and spoke model for Washington State was founded and funded to start. And this looked at instead of just, separate satellites addressing patient care, this was now how do we have a central location, right? We know that for treating opioid use disorder, we definitely want to have the patient have an established center of care. So if there was a group of different healthcare providers from different practices coming together, where the patient has a central location to get access to the care, but then be have other issues addressed by other community partners. That was the purpose, one of the purposes of the hub and spoke model. But again, same thing as providers and prescribing buprenorphine, pharmacy was not included, right? Again, you have all these pharmacies that are in neighborhoods that are easily accessible in grocery stores, things like that. But again, pharmacy was never included as part of that hub and spoke model. Now, fast forwarding over to 2023, we have the Consolidation Appropriations Act, which removed the X waiver requirement, right? So now this means any healthcare provider that can potentially prescribe, dispense any MOUD, and now it's open to more healthcare providers. So then more healthcare providers are in the community to help patients who require that level of care. And now this is where we saw an opportunity for pharmacy to step in without this barrier, right? Because it was only limited to certain healthcare providers. Pharmacists in Washington state are legally recognized as healthcare providers. We want to now use, without this barrier of the XDEA waiver, step up to the plate and become an access point for providing MOUD to patients in the community. So Dr. Bacci, along with the University of Washington School of Pharmacy, reached out and said, hey, let's start creating some, let's do some research. Let's talk to providers. Let's talk to patients. Let's talk to our community partners in pharmacy and see if we want to do this in community pharmacy, which is one of the most accessible areas of pharmacy. How do we want to do this? Let's do this right. Let's talk to the right people. So that's what led us to collaborate together and start on a research project of first interviewing the right individuals to create certain models of care. I won't speak too much on it. I'm going to leave that to Dr. Bacci to present on. But we had already originally presented this presentation to our pharmacy colleagues, but I know not for the Washington Poison Control Center. We wanted to talk to our non-pharmacy colleagues here as well, just to show you all what we've come up with our research project. So then the next thing I really wanted to show is just showing what is community pharmacy when we say this, right? There's different areas of community pharmacy practice, but community pharmacy, when we think about it, this includes our independent pharmacies, so your mom and pop shops, maybe the ones that aren't owned by major chains, right? Ones that you can go to and establish a connection with because they are in your local neighborhood, because there is a family-run business. So that is one aspect of community pharmacy. Next is something that a lot more individuals are more familiar with. That is your chain as well as your supermarket pharmacy. You know, examples of chain would include Walgreens, CVS. Unfortunately, not anymore Rite Aids or Bartell, but those would be some examples there. Your supermarkets also have their own pharmacy, a big player here in the game, Kroger, right? Yeah, Fred Meyer, Safeway Albertsons, QFC. Those are all examples of supermarket pharmacies. Walmart is also considered one, right? Depending on how that Walmart's structured. Other areas, mass merchandisers. So Costco is a really big one. They also have a pharmacy on the inside. And then lastly, not as prominent, we have other pharmacies that are considered community or outpatient. That would include hospitals that partner with outpatient pharmacies. Credina is a really big name here in this space. So the outpatient pharmacy is more so when a patient gets discharged, right? They may not have access to travel to a pharmacy in their area because they may not have one of these other pharmacies. So then a hospital may either partner with or own an outpatient pharmacy. And then lastly, FQHCs, or federally qualified healthcare centers, also have their own pharmacy. These are a lot of small groups around the state that are nonprofit and run their own pharmacy to help out and provide an area of care, clinical services, but they also run a pharmacy to provide medications to those who are uninsured or underserved. So in total, as of at least the most recent statistic, there's roughly 978 community pharmacies in Washington state. So let's break down that number a little bit in terms of what we've seen in, between 2021 to 2023. So in Washington state, we one of the things we wanted to address and show is that despite the numbers are decreasing, but that doesn't mean that the community pharmacies aren't there. So in 2023, as at least as of our most recent records, we have roughly 346 chain pharmacies, 183 mass merchandisers, 249 supermarket pharmacies, and then lastly, 200 independent pharmacies in our state. On the left-hand side, this is just a rough number of what you can find in terms of community pharmacy in the United States. But what we really want to highlight here is, this number also does not reflect the most recent Rite Aid and Bartell's closure. But we do have basically 978 potential access spots for patients to go visit if they wanted an additional place for a healthcare provider to make sure they are compliant with their MOUD, to have a place where there's a healthcare provider who can talk to them or at least connect them with resources in the community. So there's a lot of potential that we see here when it comes to addressing the patient access issue, addressing the fact that in Washington state, there is still a increasing percentage of death by opioid overdose, compared to the rest of the country. So we really wanted to take advantage of this opportunity to then create that model through these potential 978 spots for patient access. Now, really quickly, just to throw out the pharmacy aspect of this, there are a lot of medications that pharmacies and pharmacists have access to when it comes to counseling on these medications, dispensing of these medications, and potentially even prescribing of these medications. Because in Washington, we are allowed to prescribe medications under a collaborative drug therapy agreement, or in other states it's called a collaborative practice agreement, but more on that on the next slide. But buprenorphine, extended release naltrexone, naloxone, and even methadone, these aren't medications that pharmacists aren't trained on. It's part of our curriculum. We understand what these medications do. We understand that there's different dosage forms, and the best part, we can under Washington state law, not only are we allowed to dispense these, we can even administer these medications to patients under our scope of practice. So when it comes to prescribing medication for MOUD, Washington actually stands at a really nice point of being allowed to just provide those medications, assuming we follow the right protocols and things like that, in comparison to other states. So this is a graphic from the American Pharmacists Association, just showing what states are allowed to prescribe, specifically write prescriptions for MOUD for patients, as long as there is some kind of collaborative arrangement or protocol in place, in comparison to other states. So we don't have any restrictions. A pharmacist, as long as they also have the right protocol, can prescribe any of the medications that you saw on the previous slide. So let's look at some buprenorphine dispensing rates here in Washington. In terms of statistics from 2023 as well, we saw that there were 5.2 prescriptions per 100 persons per year. So if we wanted to potentially increase this rate, right, again, increasing those access points, we can definitely, as quoting the Wolf on Wall Street, those are rookie numbers. We can get those up. So if we allow pharmacies to be an access point, we can definitely increase the number of prescriptions that are prescribed so that more patients do have access to buprenorphine or any other forms of MOUD. So now let's talk about barriers to MOUD access. As part of our project, we identified a lot of different barriers to MOUD, and these are just some of the ones that a lot of the prescribers already talk about. So stigma was a really big one, right? Your patients aren't going to come see you if if they're going to feel like they're being judged. We also talked to patients who had lived experience, and stigma was also a big thing addressed by them. There were concerns about MOUD diversion, inadequate professional education and training, system fragmentation, which I think, given Washington State's hub and spoke model, is a nice way of addressing that as a barrier. There were some legal and regulatory barriers, but we just talked about how we've now overcome that with the MAC Act. And then lastly, insurance and payment barriers. A lot of these barriers that we bring up on this slide, these are all things that can be addressed by pharmacy and pharmacy teams. Pharmacists and even pharmacy technicians can be trained on addressing stigma. MOUD isn't the only medication that patients are concerned about when it comes to if they're picking it up from the pharmacy, if they're getting administered this medication. What are others going to think? What are ways for us to provide them that privacy and provide them that feeling of safety that they can get the medication that they need to, you know, feel like they're getting the right care. MOUD diversion. Diversion is something that's like bread and butter for pharmacists and pharmacy teams. So it's something we already address on a regular basis. Pharmacists, just like every other healthcare provider, require education and training. So we already have CE programs that are created by APHA, by other state associations, that addresses this education and training that now the DEA requires. And again, lastly, the insurance and payment barriers. We work with insurance and payment on a regular basis, right? With every single medication, every single bit of care we can provide patients. So pharmacy is a great way to address all of these concerns, all of these barriers. And we centered a lot of our interviews with our teams and our interviewees on how to address these as well. So with that, I'm going to pass it on to Dr. Bacci to talk about our research outcomes and what we learned and what our models of care now looks like when it comes to using community pharmacies as a potential access point for MOUD.
Thank you, Dr. Zhang. You did an excellent job of really setting the stage for the environment in which we engaged in this work. We had this policy change at a federal level that really was meant to expand the providers that are eligible to prescribe medications for opioid use disorder, specifically buprenorphine, which is one of the most heavily utilized medications for opioid use disorder. Here in Washington State, for us, that put us in a unique position because we're one of the few states where now that meant pharmacists could be prescribers. And as the data shows, while we are seeing pharmacies close, there still are hundreds of pharmacies in Washington State and across the country that could be a really critical access point for people who are looking to access medications for opioid use disorder. But we knew we needed to be really thoughtful. It's not about whether this is right for community pharmacy. It's really about, is this how community pharmacies can help support these patients and help support the healthcare team in providing this important treatment and care. So we knew we needed to talk to people who were working in this space, who were working in community pharmacies, who had the lived experience. People who are seeking care for substance use disorder are highly vulnerable, and we know there are many barriers to care, as Dr. Zhang just described. There's stigma across the healthcare spectrum, including in community pharmacy. There's payment and regulatory barriers that they face. And so needing to be really thoughtful to ensure that by engaging community pharmacies, we were helping to resolve and not exacerbate existing health disparities for this population. And also on the community pharmacy side, making sure this also made sense for them. So really a win-win, because as we've acknowledged, community pharmacies are closing because they're in a challenging place from a business standpoint. And so making sure that this would work in a way that would help the community pharmacies as well. Next slide. So we really sought to learn from our community. Our goal for this project was to develop models to support pharmacists prescribing medications for opioid use disorder in community pharmacies in Washington State. We specifically talked to people from 3 different cohorts or groups. The first, community pharmacy staff. There are actually multiple pharmacy professionals that are working in any given community pharmacy. You have the pharmacists themselves, who are the provider in that practice with the prescriptive authority through a collaborative practice agreement or collaborative drug therapy agreement. And just as important, you have pharmacy technicians who are also trained individuals who are really doing a lot of the operational work that keeps that practice functioning. And oftentimes, while you typically have one pharmacist, you may have multiple pharmacy technicians in a pharmacy at any given point. And so they are really important from a relationship aspect in a community pharmacy practice. We also wanted to speak to those healthcare professionals who are already engaging in providing care for substance use disorder, not just physicians, but other prescriber and provider types. We wanted to specifically talk to those professionals and prescribers of MOUD, but also those administrators who are helping oversee practices of prescribers of MOUD. And then finally, and most importantly, we wanted to talk to people with lived experience taking medication for opioid use disorder to understand the barriers that they face in accessing the medications and the opportunities that they saw for how community pharmacy could fit in. In addition to engaging with those groups, we also had an advisory panel of community members representing pharmacy, medicine, other health professionals, public health, insurers, additional people with lived experience taking medications for opioid use disorder, excuse me. And that group was really critical to help ensure that we were asking the right questions and influential in how we were analyzing and interpreting what we heard from our participants, and also how we then frame that into our ultimate goal of models of care for what this could look like in a community pharmacy. Next slide. We weren't starting from scratch. We really started from a foundation of what effective models for medications for opioid use disorder look like in primary care specifically. Community pharmacy is very akin to primary care practice from the lens of pharmacists are providing care to diverse patient population with a range of health conditions. So like primary care providers, the community pharmacist is often considered a jack of all trades. We'll see people with high blood pressure, high cholesterol, diabetes, helping them manage their medications during pregnancy or while they're lactating and breastfeeding. So really a wide range. And so this was a strong foundation that we could look to adapt for community pharmacy. There are really 4 core components to treatment models in primary care. The first is the medication therapy itself. And so what medicines would the pharmacist be prescribing as part of this model of care? The second component is education. And education really is 2 perspectives. The education to the pharmacy staff who would be involved in delivering the care, but also an outreach component, education that the pharmacist would be providing to people seeking medication for opioid use disorder about how to use those medications, but then also outreach to other treatment providers in their community to enable the third component, which is care coordination. So recognizing that the pharmacy would not be doing this in a vacuum, and it would in fact be very critical for them to provide this care as part of the larger healthcare team, and what that linkage needs to look like with a person's other healthcare providers if they're seeking the support for their medications for opioid use disorder in a community pharmacy. And then lastly, support services. Medications can be a large part of a person's treatment and recovery. These medicines are considered life-saving medicines because they can reduce the risk of overdose and death, and also decrease the amount of substances that a person is using. But for many people, additional supports are also important and necessary in these recovery. And so what that linkage to additional services would look like in a community pharmacy model of care. Next slide. We also know that community pharmacy teams have some interaction with medications for opioid use disorder. So we really started by outlining kind of what typical or usual care looks like at a community pharmacy right now before these regulatory changes, before these potential models of care. And right now, that is really the community pharmacies are a potential site of dispensing. So a person would obtain a prescription for the medication, bring it to their pharmacy, and the pharmacy would be the point that they would access. But the pharmacist would not be the professional acting in the prescribing role. A large part of that dispensing right now in most community pharmacies is limited to buprenorphine naloxone, otherwise known by the trade name Suboxone. Often the education component is limited to patient counseling as required by law. And care coordination and support services around that are not a big component of current care or typical care at a community pharmacy. Next slide. So we interviewed 31 individuals over about a 6-month period in late 2023 into early 2024. And these are some quotes of things we heard from people with lived experience in Washington State that I think were really powerful, but help really frame the models of care that we put together, which I'll share in a moment. One individual said, people get in trouble or they miss their appointment. They get knocked down a dose, and that just makes people want to go use. And this was really referring to some treatment programs where in trying to encourage a person's engagement, there might be penalties for a missed appointment. And so the individual was really cautioning us about how we design a model for community pharmacy that doesn't have penalties or penalizing individuals for things that are sometimes out of their control, particularly if they struggle with consistent transportation and are not in an area close to that practice, for example. Another person said, one of the biggest things for me with buprenorphine naloxone was I wasn't staying 100% clean. My provider wanted it to be all or nothing, and I couldn't do that. And this individual was again referring to some of the rules that are put in place in treatment programs, requiring individuals to abstain completely from substance use. But that's not necessarily a requirement with these drugs. These drugs can help reduce risk and reduce the amount of substance use. So again, this individual was encouraging us to remain flexible in how we designed a model of care. And lastly, one person said, it's much easier to get opioids itself than getting the medication to treat the disorder. And I think this quote really sums up the lens that our research team and our advisory panel took in thinking about how we design models of care that really keep community pharmacy as a low access point for medications for opioid use disorder. Next slide. So based on what we learned from our participants, the research team with the input of the advisory panel ended up developing 2 potential models of care for pharmacist prescribing of medication for opioid use disorder in community pharmacies. The first model is if the pharmacist were the prescriber that was starting medications for opioid use disorder for the first time. So the initiation point, or the point at which treatment is being started for the first time or after a break from therapy. The second is if the pharmacist was the site of follow-up care and maintenance. So not necessarily the pharmacist prescribing the medication for the first time, but once a person has been started on the medication, that they work with the community pharmacist for that ongoing support and care to make sure that that medication is working well for them over time and is working safely for them over time. So really the community pharmacy being a point of continuing treatment over time. So let's dig a little bit more into what each of those look like in comparison to kind of the usual care, typical care at a pharmacy right now. Next slide. So again, the first model is a low barrier model for MOUD initiation. And so this would involve the pharmacist prescribing MOUD via what we call a collaborative drug therapy agreement, so via their prescriptive authority. This model would really focus on buprenorphine naloxone, which again goes by the trade name of Suboxone, as this is a common entry point into medications for opioid use disorder. In terms of education, it involves training pharmacy staff. So there is still a federal regulatory requirement that any prescriber of MOUD needs to complete 8 hours of training. So the pharmacists need to complete that training. But as we heard through our interviews, it's really important that we think about how pharmacy personnel are helping minimize stigma, not exacerbate stigma. And so it would be important in this model for all pharmacy staff, pharmacists, pharmacy technicians, trainees, to have training in a harm reduction approach and a trauma-informed care approach. So really in how they would work with these patients in a sensitive way to really support their recovery. In terms of education to the patient, because the pharmacist would be writing that initial prescription for medication, it would be important to provide patient counseling so that that person knows what to expect from that medication, how long it might take for them to start to feel the effects of the medication, what are potential side effects, what are side effects that are what we consider more minor side effects that typically subside with time, and what are those side effects that are a signal of something serious where additional care is needed, or at least additional assessment of that side effect is needed, for an example. And then also care or education to other providers in the area to ensure that other providers and community resources know of the community pharmacy as an access point for MOUD. In terms of care coordination, it would, again, because the pharmacist would be the prescriber of that initial prescription, the idea would be they would then provide a referral, or what we call a warm handoff, meaning a very active handoff of that patient to primary care practice or specialized care provider for ongoing treatment related to their medication for opioid use disorder. So really having the pharmacist be that prescriber, but then transitioning for ongoing care to a different provider. And then in terms of support services, one of the things we heard across the board are, this is not necessarily something that pharmacists are very well trained in medications. We are the medication experts. We train pharmacists to think like how a drug would work in a body, what it would do to the body. But there's not a lot of, we're not the experts in other support services. And so it's important to leverage all of our unique expertise on the healthcare team. And so it'd be important for pharmacists to be able to refer to additional support services as patients desired and needed. Next slide. So then the second model is somewhat the opposite of what we discussed. So in this MOUD maintenance model, the pharmacist would be the provider who's providing that ongoing support and care related to the medication for opioid use disorder. They would not necessarily be the prescriber of the initial prescription. Our vision in this model would be that the medication may be started at another site, that may be a clinic or other access point. And then once that medication is started, the patient uses the pharmacist for that ongoing support. And that it could include the pharmacist being the prescriber of refills of the medication and being the prescriber if medication adjustments are needed, such as dose changes or even a change in medication after time. The community pharmacist would be the one kind of overseeing that long-term management. And in this model, our participants really saw an opportunity to incorporate more than buprenorphine, naloxone, but really the injectable medications for patients who, after they're stable on the oral medication, if they wanted to swap over to the injectable medications, that would be something that would be feasible in this model because, as Dr. Zhang mentioned, not only can pharmacists prescribe in Washington State, they can administer based on their scope of practice. Education is somewhat similar and different in this model. So again, the pharmacist would still need to go through that required training to be providers of medication opioid use disorder. And it would still be just as important for pharmacy staff to receive that training in trauma-informed care and harm reduction from a stigma standpoint. But rather than just patient counseling on a new prescription, the pharmacist education with the patient would really go to the level of medication management. So not just a few counseling points, things to expect, but really understanding how is that medication working for that individual? Is it working well? How is it working safely? Are there side effects? Are dose changes needed? So much more kind of active engagement in the ongoing management of that medication over time. Care coordination would be built into this model through kind of the collaboration with local clinics or the clinics or providers that are referring patients to the community pharmacy to be that site of ongoing care. And then similarly to the initiation model, the pharmacist would be important for them to have access and understanding of local support services and being able to provide a referral and connection when patients desired or needed. Next slide. So as part of the project that we did, it was we wanted to, it wasn't just what the models of care needed to be, but we also needed to understand what it would look like to implement them in community pharmacies. So as part of our interviews, particularly with community pharmacy staff and OUD treatment providers, we wanted to have an understanding of what we would need to think about to operationalize, to put in practice these models into community pharmacies. So importantly, needing to consider regulatory requirements. That would be things like the required training for prescribers. There would be some additional registration pharmacists need to complete to have the ability to prescribe controlled substances, because buprenorphine and naloxone, they are considered controlled substances. It would involve pharmacy staff training, importantly, all patient care, how it's documented and paid for, making sure that pharmacies have the space, in particular the private space, to provide this care. Another key consideration is medication inventory. The Drug Enforcement Agency requires that drug wholesalers have methods for identifying unusual orders of controlled medications. As I mentioned, many of these medications are controlled and they are subject to these monitoring programs, and that creates a problem. To be really frank, for pharmacies, making sure that they have this medication in stock for the patients that are looking to seek it. And so how we work with drug wholesalers around making sure that the pharmacies have access to these life-saving medications so that people in our communities can have easy access to them. Also, the local community resources and partnerships that the community pharmacy might need. So this involves building the relationships with clinics and other resources in the area. So to help with patient referrals, that patients know the community pharmacy is the site of this care, but then also the relationships with additional support services and having places to refer people for assistance with other aspects of their recovery. And then lastly, marketing and advertising, again, to ensure that the community is aware of that the pharmacy is an access point for this. And so next slide, we took all that we learned and we created a guide for community pharmacy teams. We've included a link for it here on this slide. This guide outlines the models of care that we've walked through today in additional detail, but they also outline these implementation considerations and have a checklist and additional resources for how a community pharmacy would need to think about each of these kind of operational aspects of this model of care. Next slide. And we're very excited that we're now at the point where we are putting one of these models out into the real world to test and learn what works, what doesn't work, and evolve it as we go. This is important work that, of course, cannot happen without partners. And so this project is really being done in partnership of the UW School of Pharmacy, the Washington State Pharmacy Association, CPSN Washington, which is a clinically integrated network of 45 independent pharmacies in Washington State that are really well positioned to be early adopters of this model and in providing this care. And also Scala Northwest, which is a provider support network and works with hospitals and emergency medical services to have emergency departments and EMS be the point of initial treatment or prescribing of MOUD. So in this next year, we're going to be putting the maintenance model into practice, where Scala Northwest sites will be that initial prescribing, the initiation of the medication, and then patients can be referred to pharmacies to be the site of ongoing care. And again, this is the approach to this is we listened and we learned a lot, and we're sure that probably not everything's going to work totally perfectly. So this is going to be about how we adapt and revise the model as we put it into practice. So as we close today, I just want to acknowledge, next slide, the other members of our team, Drs. Clayton English, Anthony Floyd, Sierra King, Jenny Arnold, and Ryan Hansen, who've all been critical to this work, as well as our funders, the Community Pharmacy Foundation, which funded the work to develop the models that we've described today, and also the University of Washington Population Health Initiative that is funding this next phase of work as we put this into the real world. So with that, we'd be happy to answer any of your questions.
Wonderful. Thank you both so much. This is really interesting work. It looks like we do have a couple questions. We'll start with Shelley Little in the Q&A. She writes, in our community, pharmacy will not dispense Suboxone until later in the day, even if the doctor prescribed it the day before. What could be a reason for this? Many of our families have to wait far too long. Could it be because the refill isn't, quote, up and not due until that specific day or time? We do not do that with other medications.
Go ahead, Dr. Bachi.
That's a great question. I don't know that I have a specific answer because I haven't heard of that practice specifically in community pharmacies. But what is coming to mind for me is it is likely a protocol for that community pharmacy, because pharmacies are currently being put in this position where they're being asked to police controlled medications at the same time they're being asked to provide care. And so I referenced that the monitoring program that drug wholesalers are putting in place. And so it may be related to some of those policies. So really kind of some changes that are needed within federal policy that can help kind of make that supply a little bit more accessible. The other thought that's coming to mind is, that because sometimes supplies are limited because of those monitoring programs, a pharmacy may need to wait till they receive their order that day. And that typically that can happen late morning, midday, even into the afternoon. And so it may be about when their pharmacy gets their order in for that day and then have time to fill it and ensure appropriateness of that medication for that patient. Dr. Zhang, what would you add to that?
No, I would echo the same thing. I used to work in long-term care pharmacy, and we were also dispensing Suboxone to patients. And one of the difficulties we ran into was providing a full day supply. So we're limited not only by what the doctor can write to prescribe to their patient, but then if we don't have the full supply because we're limited by our distributor of how much we can get, then we need to wait for the supplies to come in to then provide the full amount to the patient. And these medications, we've been fighting for supply access issues on a national basis now. At the moment, right now, the DEA and the FDA are pointing the fingers at the distributors are pointing fingers at the federal government. And it's a bit of a chaos that we're trying to navigate to make sure, like, hey, we're okay with these limitation programs, right? It makes sense. We want to make sure the right people get the right medications. But now we are trying to work with our distributors by saying there are now more patients who require specific dosing regimens, or the day supply just doesn't work anymore, especially that 2-week limitation. So we're hoping to address that concern, so like when we do receive the medication in the morning, we can provide a full supply rather than a partial supply, and then the patient ends up going elsewhere and other issues.
Excellent. Folks, if you have more questions, please put them in the chat. I see one other here. Pardon me if I butcher the name of this drug, is the non-opioid pain drug suzetrigine or Journavax used for opiate use disorder?
Yeah, to answer that question, Dronavix is currently not indicated for opioid use disorder, just because it doesn't work on the opioid receptors. The earlier slide I had with the medications, it shows those primary targets, right? Those mu and delta opioid receptors are the ones we're trying to hit when it comes to mechanism of action and MOUD. However, I will say that we actually had the company who makes this medication present to us at earlier this summer, and I was sitting in on the presentation and did ask, like, hey, because this is a non-opioid pain medication, are there plans to incorporate it as part of general care for patients with opioid use disorders? So instead of, tapering off on a opioid and then using this medication as a substitution so that the patient has a different alternative to being weaned off of opioids. So while it's not directly indicated, it has the potential to be used as part of general therapy when it comes to MOUD.
Excellent. Thank you. Brenda says, thank you. She asked that question. So I had a couple questions. Can you talk about, like, are there differences in community pharmacy MOUD in rural versus urban settings? Like, is there, I know in a lot of our practices that tends to sometimes be a challenge. Does it translate here, or is this a way around that?
It's definitely a consideration here. From a few different lenses. Pharmacists in rural areas find that they often are providing higher levels of care to community members because of the more limited access to care all around. And so we think that this model particularly has real relevance in rural settings to help where there may be limited access to care sites and care points for MOUD right now. And it has utility in urbans for different reasons, right? In an urban, highly concentrated area, where people may not have cars, the distance to travel to care looks different and is often much shorter than in rural areas. And so I think what we've learned through the work is in all settings, it's about understanding the needs of that community. There may be sites, pharmacies where it doesn't make sense for them to implement this model of care because there are sufficient access points in their community. And there's maybe something that that community needs the pharmacy to be doing more. And we anticipate that's where we had hypothesized that that's likely more relevant in an urban environment where there are just generally access to a bit more resources.
Thank you. I had another question. Dr. Zhang, when you presented the map with states that had fewer restrictions versus greater restrictions for MOUD prescriptions, I know it's like Massachusetts was one that had more restrictions. What are some of the restrictions that pharmacists in other places face? I want to especially highlight, like, if we're doing a great job in Washington State, like with reducing these barriers, then wonderful. But I'm wondering what barriers exist in other places as well.
Yeah, the biggest barrier I would like to point out is honestly just scope of practice and prescriptive authority. So right now, we're still trying to make it an active effort to allow for full prescriptive authority for pharmacists in the US. However, it's a slow state-by-state battle at the moment. So, pharmacy is actually one of the most highly regulated professions in the entire country. And every state has their own laws in terms of what a pharmacist can and cannot do. So when it comes to Washington, we have the opportunity to prescribe any medication under collaborative practice agreement or a collaborative drug therapy agreement. But some states, they are so specific on what pharmacists are allowed to do that they have to pass laws one by one. As an example, Vermont is one I like to bring up from most recent memory. They had to pass a law specifically just for tobacco cessation, right? Instead of just saying, like, hey, if the pharmacist is properly trained if they get additional training, if there is anything else that they can do based on their, doctorate level degree, then just allow them to do it in collaboration and agreement via that contract with the provider. But they don't have that ability, and instead they have to go through the whole legislative process, which takes 2 to 3 years just to say, hey, pharmacists are really good at tobacco cessation, let's allow them to do that. But that means for any other healthcare condition, now they have to pass another law to allow for a pharmacist to help with that disease state. So there's a lot of just major legal barriers that impact the ability of a pharmacist to practice.
And I would also add, there's the impact from a pharmacy law standpoint, but there's also from laws that govern access around opioid use disorder treatment and these medications at the state level. I'm not exactly sure of the restrictions in place in Massachusetts, but I know there's a group that's working on a similar thing in Tennessee. And in theory, pharmacists should be able to prescribe there because there's nothing in their pharmacy law that would prevent them from prescribing. It's actually in the substance use disorder and MOUD state law where they define who can prescribe these medications, and pharmacists are not on that list. So it's the state putting additional restrictions on it, kind of within a different sphere of regulation that's become a barrier for them.
Excellent, thank you. I see a question popped up in the Q&A for Huva as well. They say, Sarah says, thank you for sharing your work. What are some considerations for adapting for different pharmacy settings that you have found? I can imagine retail pharmacy versus grocery versus independent might have different resources and support for implementation.
Yes, that's a great question. There are probably many, some of which we're aware of at this point, and those that we're not aware of that we're expecting we're going to become aware of in this next phase of work. But some considerations we're aware of are staffing. Often independent pharmacies have a little bit higher level of staffing in current environment compared to perhaps a chain pharmacy. And so that puts them in a place to be able to offer additional services. In addition to that, also kind of workflow, appointment scheduling. So often community pharmacies are accessible and wonderful sites because people can just walk in and get access to a healthcare provider whenever they need. But often there's kind of multiple things happening at a pharmacy. So how we set a model up to work well from a workflow standpoint. One of the challenges with the initiation model, for example, is it works best if someone doesn't need to make an appointment, that at the point they decide to seek care, they can walk into a pharmacy, talk to a pharmacist, and get access to that medication in real time. And that's a little bit harder to plan for from a staffing and workflow standpoint. And so that's actually one of the reasons we're starting with the maintenance model, because as part of the referral structure, that person will get set up with some sort of appointment. We'll be working with each pharmacy because we imagine that we are working with, it might look a little bit different. Some might need a very kind of strict appointment routine. Some may have more flexibility in terms of if you come in on this day. So we're going to be figuring some of that out. And then lastly, the other big one is from that documentation piece. Pharmacies have always looked a little bit different than other healthcare provider sites because oftentimes we're billing under the drug benefit rather than the medical benefit, and the documentation around that has always been different. We're in the process of transitioning as pharmacists are able to provide services related to medication management, but that's another change process we're navigating in terms of documenting and having those documentation systems communicate effectively with other healthcare provider systems. So those are just a high level kind of summary of some of the big implementation considerations, particularly as they relate to independence and chains.
Great, thank you. That looks like all the questions that I'm seeing right now. Would either of you, do you have any last words for us?
Final words would be, we're hoping that everybody learned a lot from this presentation. Again, you saw what our research just produced in our phase 1 of what we're hoping to do. Of course, no plan is going to be effective without implementation. So we're hoping not only are we in the next phase of project, we'll come back with better results, especially with our maintenance model. But we're still actually continuing to apply for more grants to also continue pushing this into the community, especially from a financial standpoint as well, looking at that, is it financially viable to have a pharmacy do this, as well as then once more pharmacists, pick up on this, right? If we were to move into mass merchandisers, chain pharmacies, could we then make a great enough impact in, again, Washington's numbers versus the rest of the country when it comes to MOUD and OUD access? But please do reach out to us. We're continuing to look for additional partners to work on this. And of course, we're always more than happy to present our data and continue learning ourselves more on what it means to provide increased access to MOUD in the community.
Wonderful. Thank you. And thank you for presenting for us today, but also just a larger thank you for the work you're doing to promote access to MOUD across our state. Like I think it's just really, really important and it's life-saving. And I recognize that. So I just really want to express my appreciation for you all and your time today, your expertise again. And thank you.
Thank you very much.